So for the final lecture of this module, we're going to talk about the management of bowel obstructions. In my last lecture, we really focused on the X-ray imaging because really for the diagnosis of a small bowel obstruction, the X-ray and the history, again, obstipation, are the key features that make the diagnosis of a small bowel obstruction. You'll very frequently know, though, in the wards and in the emergency department, we'll use a CT scan to kind of help our diagnosis and management of a bowel obstruction. And the real role of the CT scan is to assess the cause and the severity of the small bowel obstruction. They'll help identify whether there's a cancer or adhesion that might be responsible for the obstruction, or it could even give us some information as to whether there's an area of the bowel that's at risk of perforation because there's a closed loop bowel obstruction, or an area where there's poor blood flow to that loop of bowel, indicating possible ischemia. When you're dealing with a patient with a bowel obstruction, you want to decide, do I need that extra information for a CT scan or not? The other things that you'll do is you'll usually insert a nasogastric tube, and that has the purpose of decompressing the stomach, making them feel better, stopping the perpetual vomiting that they usually have, and it'll help decrease the distension of the small bowel. If you're dealing with an adhesive small bowel that's not a closed loop bowel obstruction, that might actually reduce the risk of perforation and help it resolve down the road as the edema settles down. In addition, as we talked about blood work on the last lecture, you want to check the electrolytes. Make sure they're not too abnormal, because if the patient's been vomiting for a long time, they can essentially have a metabolic alkalosis from all that vomiting, and you may need to actually correct that type of abnormality. Also, you're going to want to do serial abdominal examinations along with serial x-rays to follow that person during their hospital stay to determine they don't develop peritonitis and don't have worsening distension of their small bowel on imaging that might suggest an impending perforation. When we're dealing with a small bowel obstruction, one of the strategies that we use is this Gastrographin study. Now, it has two roles. First of all, it helps us determine which patients are likely to resolve, because 80% of small bowel obstructions typically will resolve on their own. So what we'll oftentimes do is we'll give a patient a Gastrographin meal, and this is a contrast agent that is water soluble, it's hyperosmolar, and we can follow that along over a 24 to 48 hour period, and if we see that that contrast bolus ends up in the colon, we know that the patient is going to resolve because they were able to pass the contrast through, past whatever the obstruction was, and is now in the colon. So it's a sign that they're actually opening up. If they fail to pass that Gastrographin, then that's an indication for surgery. In addition, if we're concerned about a closed loop bowel obstruction, that's an obstruction where there is a blockage on 2 points of the bowel, that would be an indication for surgery. In more detail, this closed loop bowel obstruction, again, is this obstruction where there's a blockage at 2 sites of the small bowel or the large bowel, and there's a greater risk of vascular compromise as well as a greater risk of perforation because that loop cannot be decompressed by vomiting or an NG tube, and so it stretches and stretches until it has a risk of perforation. The typical situations for a closed loop will be situations where you're dealing with an adhesive band, a volvulus, or internal hernia. Things like strictures or neoplasms are much less likely to cause this closed loop bowel obstruction. And as a concept, it's really important to understand that all large bowel obstructions are essentially closed loop bowel obstructions. And the reason why this is because the large bowel cannot effectively be decompressed through the ileocecal valve. You'll remember from the x-rays in the last lecture, there's almost no air fluid levels and gas in the small bowel because despite the large bowel obstruction, the small bowel was still dumping its contents into the colon. So large bowel obstructions need to be treated and thought of as closed loop obstructions. There's no effective decompression. The symptoms of a closed loop bowel obstruction are worth paying attention. They'll oftentimes have colicky pain temporarily that will progress to severe continuous pain because that loop of bowel becomes distended and is unable to be compressed. On physical exam, they may have point tenderness over an area of one loop of small bowel that's compromised. They may develop peritonitis, and they'll oftentimes be relatively unwell as that loop of bowel has concerning vascular supply, and so the lactate might be elevated. If you suspect a closed loop bowel obstruction, that's an indication for urgent intervention, not an indication for serial examinations. And we want to avoid perforation and necrosis because when that happens, that increases the probability of mortality when we're dealing with a bowel obstruction case. The other indication for surgery that's consistent in bowel obstructions is this issue of the non-adhesive small bowel obstruction. Non-adhesive bowel obstructions will not resolve with time and a nasogastric tube. And surgery is indicated because that is typically a presentation of a more severe pathology, like a cancer, at its first presentation. So going to the operating room on a non-adhesive small bowel obstruction more often than not results in resections of a component of small bowel or a diagnosis of a more severe pathology. One of the causes of bowel obstructions that we mentioned was volvulus. And here's a good example of a sigmoid volvulus. This is one of the more common large bowel volvuluses. And it gives you a sense also as to what's happening in a closed loop obstruction. Here we have a redundant sigmoid. It's twisted around its axis. And if you think about it, although that twist looks like one point here on the imaging, it actually represents 2 points in the colon. And so essentially this loop is blocked both on its exit and its entrance. And you can see that it can develop in a distension that cannot be decompressed in any way. Again, a volvulus is an indication for surgery. Now, I should also mention that there are some other tools to deal with a volvulus. For example, a sigmoid volvulus could potentially be untwisted by endoscopy, but again, I would consider that in the same category as a intervention to actually directly treat that obstruction. So it would be similar in my mind to surgical management. A common picture you'll see on an x-ray is this coffee bean shape. This is a picture of a sigmoid volvulus. You can see the apex of the coffee bean is pointing towards the left lower quadrant, and that's consistent with a sigmoid volvulus. But also appreciate, this is a huge amount of distension. You don't have the context of the rest of the image other than the person's vertebral body here. Typically, we would say the vertebral body is around 4 centimeters. So you can see there's massive distension here. You could probably put 3 vertebral bodies in this one loop alone, which is going to put you around 12 centimeters. So it's going to be very serious risk of perforation for the sigmoid volvulus. So this is an indication for either that endoscopic decompression or surgical management. And typically, if we're going to decompress it endoscopically, we're going to also follow it with surgery because the risk of retorsion or revolvulization is high. So in summary, for management, CT scans are useful to guide our management. They help us determine the difference between a closed loop obstruction and not, might identify more severe causes, and might identify areas of the bowel that are risk of ischemia or perforation. The majority of small bowel obstructions will resolve on their own, 80 to 85%. Serial abdominal examinations and serial x-rays are useful to help guide the management if we're going to attempt non-operative management of a small bowel obstruction. And essentially the indications for surgery are any non-adhesive small bowel obstruction, a closed loop small bowel obstruction, or any mechanical large bowel obstruction, or an obstruction that fails to resolve over time.